have Dr. Bagrodia joining us from UC San Diego. This time is actually not a cancer talk per se, but more of a um, surgeon lifestyle talk, I guess might be a better way to say it. So I'll let you take it over. And thanks again for joining us.
Yeah, thanks really for the invitation. It's great to see the group again. And before we kind of jump into it, I thought I'd share some context. In 2022, at the Society of Urologic Oncology meeting, there was a panel on basically the emotional toll of surgical complications, how it impacts us. And I was asked to participate on that panel by Scott Egner, and I remain very grateful to him for asking me to. And the charge that Scott gave me was, really try to take a deep dive into what life is like after a complication. It was myself, Amy Luckenbaugh, Kevin Turner that were on the panel, and Jim McKiernan. And he kind of gave us each a little bit of a role and responsibility. And since that time, it's kind of amazing to me when that topic was proposed. It was the first time I'd ever really heard about or thought about this topic in any formal context. That was 4 years ago. I'd never been educated on it formally, and as a medical student, as a resident, as a fellow, or as an attending, is one thing that kind of jumps out. And the second thing is, is really kind of a transformative and pivotal experience in my life, in my career, where it struck a chord with me. It caused me to take a little bit of a deeper dive into this topic and do what I can along with many other people to help, because this is something that we all face. It can be challenging, it can be rough, and it can be life changing. So what I'll do is I kind of want to start out by sharing an experience, and then maybe we can pause for a moment and have a conversation. There might be some other experiences that people want to share, questions or a conversation that arises, and then depending on how we're doing from like a timing perspective, the second, you could say two-thirds, is a little bit more on incidents of adverse psychosocial events on surgeons and things that we can do about it. All right, so with no further ado, and thank you again so much for the invitation. I'll start out by sharing a case. So this is a patient of mine in my third year of practice. He was a 43-year-old man who had metastatic seminoma. He received induction chemotherapy, growing masses, got salvage chemotherapy with persistent growing PET positive masses, and he was counseled for a post-chemo RPL&D. Tough case as billed, salvage chemotherapy, seminomas, tissue planes were challenging, but nothing particularly noteworthy intraoperatively. And afterwards, he was admitted. He kind of languished, developed an ileus. It turns out he actually had pancreatitis and some sequence of drains, NPO, TPN for the next 2 or 3 weeks. And then right about a month after his RPL&D, I was at the hospital. I get a call that this patient was acutely very sick. And he was hypotensive, he was tachycardic, he was diaphoretic, and it was pretty much a clinical diagnosis of an acute and significant bleed. So we rushed him down to the operating room, did a laparotomy. His abdomen was completely frozen, and had our colleagues in IR come in. They shot an aortogram, which you can see here, and he had a complete blowout of his aorta just below the renal vessels. Um, Probably, the pancreatitis with the enzymes there just eroded a attenuated aorta. They actually got a balloon in, and then the cardiac team did a thoracotomy. And by the time they did all this, he had an acute atrial thrombus and he died. And it was such a unexpected and shocking course of the events today. I really didn't know what to do. I went and I talked to the patient's family. I've been seeing them every day for a month. I had this long-standing relationship, even as he's getting a systemic therapy for his testis cancer. And we sat there and you know, was there for her. Then afterwards, I went back to the operating room, and by this time, colleagues in cardiothoracic and IR and other surgical specialties were there. I started closing the wounds. And basically they're like, "Aditya, why don't you get out of here? Well, we can take care of this." And reluctantly, I left. I got in my car. I drove around, and honestly, I didn't even know what to do. I ended up coming back to the hospital. I just walked into the surgeon's lounge and saw like one of my partners and just broke down crying. The residents and fellows, all present. And the next day, I even that night going home ultimately and seeing my family, at this point, my children were 4 and 8 years old. It's just extremely unusual to go home after what I would consider an extremely traumatic day and have some semblance of like a normal evening or next day or next day. Um, but the next day, I got a call from the patient's wife, and we talked, and she actually thanked me, told me I was going to be in this patient's obituary, and invited me to the funeral. And I'll read the some excerpts from this obituary. This is when I was still at UT Southwestern, and it reads: "The patient, 43 years old, of Arlington, Texas, passed away at UT Southwestern. He was a strong man of faith who left handprints on so many lives. He could light up any room with his godly wisdom and goofy charm. He was a family man who adored and loved to spend every minute he could with them. He was the best father, husband, and friend you could ask for, and had a passion for art, graffiti, DJing, music, break dancing, drawing. And he was a lifelong dedicated Yankees fan. In his youth, he spent time working with disadvantaged kids." And the last sentence of the obituary reads, "We'd like to say a very special thank you to Dr. Aditya Bagrodia, who from day one was a trusted surgeon and friend." And the way that that made me feel was awful. And it was super complicated. Like, how could I ever be considered this patient's trusted surgeon and friend where, and so I was singularly responsible for him dying. And I went to the funeral. I met his parents and his kids and his siblings, and that was also it was a jarring experience. And I don't even know if it was a good idea to this very day to go. Um, and when I was thinking about this and preparing this, obviously, there's a full gamut of the way complications can go in terms of acuity, et cetera. And first things first, we of course talk with the patient's family. And I went alone to talk with the patient's family. In retrospect, it might have been a good idea to take a trainee with me. I spent, a lot of time with them, sitting with them, sharing my, the trauma that this had put me through, as well as a distant second to everything that they were going through. And then there's really this feeling of numbness, blame, guilt, self-loathing, like denial, like, is this even happening, both during the actual complication itself and then afterwards as well. And it's cumulatively just a terrible, terrible feeling. And then you go home, as I mentioned, it was very hard for me to talk to anybody about this. Minimal interaction with my family, drinking, just try to forget about it, make it go away. And a lot of times I'd have just keep thinking about it during both the day and the night. What all happened, what's going to happen the next time, and then you go to work the next day. Um, and quite possibly nobody has any idea what you've been through. And I think one of the foremost thoughts is and feelings is a loss of competence. Am I competent to be doing these cases? I feel like I've trained at high volume centers and UT Southwestern and Slow Kettering. I was hired or offered a position at everywhere that I've trained, decent surgeon. Um, but you ask yourself, like, should I be doing these cases? And it's very difficult to provide instruction in the OR. Um, if you did cases with the same trainees a week or two prior and they come in and it seems like a little bit of a reinventing the wheel, am I in a position to be instructing them um, or giving them, some feedback on what they're doing? M&M, forget it, zero interest or place uh, to provide comments, constructive feedback on things that might have been done differently. And then, me personally, believe it or not, I'm actually somewhat introverted, and there was almost no discussion with trainees, with partners on how I'm doing. And then this global feeling of embarrassment. You know, are what have I done here? What are the trainees thinking? What are the residents thinking? What are the fellows thinking? What are my partners thinking? And then obviously in a kind of a high profile case like this, like what are my colleagues across the institution um, thinking about me? And, in addition to a psychological toll, I think there's a physical toll. This is 3 years and, maybe one's always a little bit more scrutinizing on themselves, but I feel like I, physically changed, like my constitution, just like a different person that just aged tremendously, particularly in my early days as an attending. And it doesn't really stop with us. When I was putting together this talk, I asked my wife to send me an email of what life is like with me after a complication, and I'll read a excerpt. Aditya is the type of doctor I'd want. He's always on call for his patients. He gives 110% to each patient, and when a patient has a bad outcome, it affects him deeply and personally. It's hard to pull him out of this. He's not a talker and tends to fold into himself. After a complication, I rarely feel like I have his undivided attention. He becomes more engrossed in his work and hypersensitive to details. He's missed important family events, including our son's birthday and Diwali, taking care of his patients when not on call. And I mean that's an excerpt, but it was very eye-opening to me on just how massively it impacts not just myself, but people in my family. And then of course there's the patient's family. This is a case that I had. It was a complication more so than an error, where a elderly patient had a sequence of events and required a prolonged time in the hospital. And this is on Thursday, December 16th, one day before kind of Christmas break. And I get a text message that says, for the record, I'm disturbed by the fact that you're leaving, will not be able to see my mom for at least 8 days. If you're indeed leaving, I demand a personal introduction to whoever you're so strongly recommending as your replacement and CEO of the hospital. I'll only take a couple of minutes. And I talked to our CEO. Our CEO is Chris Kane. He's a urologist. And I was this close to just canceling the holiday plans and trip that we had scheduled just to be there and round and honestly not even offer anything at this point. It was kind of multidisciplinary, higher level medical care, nothing that I was doing. And this is something I still kind of struggle with, boundary. And of course, Chris was like, you absolutely have to go on, go heal and be with your family. And that's not appropriate at all for this person to put you in that position. And I think boundaries are very very complicated. And it's, with anybody, and certainly when you're having a complication, what degree of personal contact, how do you interface with difficult families, being over involved where I think honestly bilaterally it can be a bit pathologic with excessive communication. And this doesn't even really kind of discuss or talk about the risk management elements of it, which nearly certainly in the literature would suggest amplifies everything significantly. But I think I've evolved. I finished my fellowship in 2016, so I'm almost 10 years into practice. And of course, when something happens, talking with the patient's family, that's 101. I think they can appreciate and see that this is really really hard for us, that we went into our profession to help people, and when that doesn't happen, it's really awful for everybody. Talking with trainees and partners about this, I think this is also something that's extremely important. I had a complication a couple years ago. It was nothing quite as dramatic, and we went and got some appetizers with the residents and actually a couple members of the team, the circulator and the scrub tech that were involved, and we just kind of talked about it. I think they saw a different side of me and of everybody else, and overall, I think that was quite useful. I periodically get calls from people that I know well, and honestly, sometimes not though that well, that just share, something they've been through, and I think that's something that's useful for all of us. Then all those terrible feelings that come along with the complication, I've really just started acknowledging that this is a normal response to trauma, and that I'm going to need some time to process it, and feeling really really bad about the way thing went is super normal, and just allowing myself to kind of interface with that has been useful. I'm talking to my family. My kids now are 9 and 12, and I could tell them that I had a tough day at work, and one of my patients isn't doing so well, and they get it and they're supportive. Similar to my wife, she's a pediatrician, and she also kind of has her own um, issues in terms of taking care of patients when they don't do well, and it's nice to be able to talk about that with somebody. Generally shifted away from drinking. That's not a mature coping strategy. I don't think it helps anything. It's well known in any type of coping strategy, and the impact that that's had in terms of sleep hygiene and overall processing, feelings about myself has I think been a step in the right direction. The loss of confidence, this is the challenging one. Um, on the one hand, and some point, every chief resident and fellow, I always talk a little bit about the man in the mirror test, the person in the mirror test, and as long as these aren't patterns where you're starting to see unusual or frequent complications, I think if you can ask yourself, did I try my best? Did I cut any corners? Did I stay till the job's done? It doesn't make any of this go away, but allows you to re-engage, and not feel embarrassed about how a case went or what people are thinking. And then again, I think normalizing this, discussing it, um, confirming that nobody feels alone is really important, for my own personal management of complications, and then for our field as well, absolutely kind of including the trainees. And with complications, I mean, everybody's heard this or was told this somewhere along the way, that complications are going to happen. Um, I think that complication management, in terms of how we deal with it, is absolutely a dynamic process. Um, None of us are alone. Everybody's had this, and as long as they're taking care of patients, it doesn't even need to be doing surgery. And I do believe that you can't really take care of other people without taking care of yourself. And this is an important part of self-care, burnout prevention, wellness and happiness that I think is critical. And finding that right balance with patients and their family is very, very tough. I think it's something I continue to struggle with. I don't think there's a right answer. Every case is different. Every patient is different. Every patient's family is different. And for our own self, I think one end of the spectrum can be paralyzing empathy, where you really receive it hard and have a hard time bouncing back. And then the other end of the spectrum might be over compartmentalization, where we don't really interface, we don't really think about it. And I think, as as people, if this doesn't affect you or cause some internal struggle, that's not an entirely normal response. So I'd like to pause here. This is a quote from Rene Laricki, who it's almost 75 years old, and he states that every surgeon carries with themselves a small cemetery where from time to time they go to pray, a place of bitterness and regret, where they must look for an explanation for their failures. So while it may not have been as formally recognized or termed, I think this phenomenon is as old as our profession itself. And I'd like to just pause here to hear any comments or feedbacks from any of the people on this call, residents, faculty, before we kind of talk a little bit about, the incidence of this problem and what we can do about it.
So, Dr. Bagrodia, this is Wayne Hellstrom, and I'd like to give you a corollary that occurs on occasions. I do men's health, so we're more prone to litigation. So sometimes you do things perfectly, patient's not happy. He basically hires an aggressive lawyer who sends you horrible things. And this probably intensifies. In your case, the family was very supportive of you. But sometimes you're put into a corner where you're dealing with where you did everything right and things do happen. So this is a crawly that happens that will happen if you practice enough, not only complications, but you will get lawsuits. And it follows along the same line that you're talking right now, because sometimes you have to introspect and you have to ask yourselves, and the opposing attorney is giving you all these miserable comments about what a piece of shit you are or something, so that you have to deal with that too. So it follows along the same line that we have to deal with this. The other thing is that Rene, it's Lariche, the name, not Larique, something like that, but Lariche is the name in French.
Nourish.
Yeah. Yeah, thanks for that comment. And I think that scenario obviously carries with it a whole nother set of considerations, and it's pretty well described that if you've been named in a suit, that can really have a lot of the similar adverse effects that occur after complication, anxiety, depression, problems with sleeping, substance abuse, uh, basically not doing certain types of cases again. And it can be especially isolating because basically you can't talk to anybody about it. That's essentially like the first thing a lawyer will tell you is that you cannot discuss this case with anybody, because that's all discoverable and nearly certainly can be used against you. So it's absolutely kind of in the same vein of what we're describing, and whether or not there's a complication, just being named can heighten the temperature in the room and leave one in an extremely isolated position.
Aditya, hi, Brian Eisner. First of all, thank you. It's easy to get up and talk about how many PCNLs I've done or how many radical cystectomies or RPLMDs you've done. It's not easy to have this kind of conversation. You clearly are teaching the world about it, but it's hard, and I'll tell you that one of the reasons why I wanted to speak up now is I had a death early in my career. And what actually helped me get over some of this was Scott Egner's editorial Murderer in the Mirror, which I don't know if you're going to talk about in your lecture. And somebody connected me with Scott, um, and he helped me a great deal, and I think that, I mean, I don't want to steal time from your lecture, but I'll say that um, you are not alone. I know you know this, but feelings of, am I qualified to teach this? Feelings of, what will my trainees think about me? Feelings of, I had a death after PCNL and another one after ureteroscopy, you know, and again, I don't think anyone would ask if it was a surgical error. They were just terrible sepsis complications, but they happened after I operated on someone. You know what I mean? And another incredibly interesting thing that happened to me that I would like to share, because I want to almost see the reaction on your faces. I had a death after ureteroscopy, and 3 years later, her sister came to see me as a patient. Um, and I think some of it was, that like you, I think the family didn't really blame me, although I blamed me. Um, but I think that we as surgeons are taught sort of not to talk about this or to internalize it. And I think that some of the things that resonated with me that you said are also that my wife does try to listen and understand, but she's not a physician, and it's not just about the event, but then getting back in the saddle the next day, and or the next week, and doing it again and again, or when someone says, have you ever had someone die from this surgery? And you got to look them in the eyes and say yes and relive it. And so I'm very anxious, very excited to hear the rest of your talk, excited in sort of a, interested way. But these are not easy things to discuss. And you're right, we could speak about them for a lifetime, and we probably need to have more panels at our meetings about this stuff, right? Because this is the stuff that's not in any textbook. This is the stuff that you learn from friends. And it's interesting, as you were speaking, I was looking back at my old texts with Scott, who's become a friend. And what's interesting is a few years later, he texted me about a colleague of his from U Chicago and said, "Hey, Eisner, one of my younger colleagues had a bad complication. Mind if he gives you a call?" You know what I mean? And I think that that's really what some of this is about, is paying it forward and sharing our experiences so that people know that we're not alone. And it can be very, very, very lonely when you think, I'll say, when I think that I killed somebody or that someone died in my hands that would not have died if they didn't have that surgery. So I just want to express gratitude. I want to kind of shut up because I feel like you probably have a ton more to say, but express gratitude for your sort of bravery and courage in talking about this in such a way and teaching us, because many, 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 many more people have been there than will get up and speak about it and use it as something to teach all of us. And I've already learned a ton just from what you've said, even though I already thought I knew it, but I'm grateful for what you've expressed and looking forward to the rest of it. But I think, you're not alone, as I'm sure you know.
Yeah. Thanks for sharing that, Brian. And um, I have no doubt that she would have no problems with me sharing this. But last year I went back to UT Southwestern. It was the first time going back after training there and being attending for 5 years. And I basically gave this talk, and like Peggy Pearl, who's like my first mentor, and was just in the back bawling the whole time. And she was just like, there's expectation of perfection that's both internal and it's external. And when it doesn't go perfectly, I think we just rake ourselves through the coals. We berate it. We all know about expected complication rates, and somehow, despite that, don't think it's going to be about us. Um, so I definitely appreciate those comments. And I kind of kicked off with Scott's, who got me involved with this whole area and of research and scholarship, and what he's done is truly amazing, and what he continues to do. And I think there is kind of this like informal reaching out, and which is good. And a lot of times the informal reaching out is, you're a great surgeon, generally telling somebody of a even worse complication that you've had personally, telling them to get back on the horse. And that's a good starting point, but like surely we can do a little bit better than that. And in terms of the rest of the talk, like, that part's important, but I absolutely just want to make sure that if there are any comments from other members, we just get a chance to run through those, either now or at the end. So before we kind of get into the incidents and what we can do about it, I'll just pause for another moment to see if there's any other comments or questions from anybody, including the trainees.
Aditya,
Please.
this is Raju. Can you hear me?
Yes, yes.
Yeah. So, I've been through all this. Being senior to you, I've had patients down the table, and I've put this as a talk and evaluation as the wounded surgeon. How can we unwound the wounded surgeon? And the stuff that you already mentioned, is first to look at yourself. So if you look at your case, the indication was there. And this morning we had an M&M where a patient died, and we were trying to explain that to the M&M team. The indications for your case was perfect. You had a mass that had to come out. You gave the chemo. After chemo, the whole thing collapses onto the vena cava and the aorta, but you took that out. Sometimes little traction of the pancreas can cause trauma, lead to pancreatitis, leakage of pancreatic fluid, and then you manage for the next month. And you ever heard about the aorta being eaten in two? So this is a very rare thing, Aditya. So you did everything that you could, right technique and everything else. So number one, when you're young, uh, you tend to take it rather tough, but I think it's going to happen to all of us, even with the best of intentions, because every patient is different. Uh, so getting back on the horse is a good thing. Not drinking too much, because one of the side effects of the wounded surgeon is they get to drink too much, and uh, making sure that you work up the patient. All the cultures are negative and stuff, and all that starts in residency. So as much as my residents think I'm picky about certain things, it is so they will not be wounded, is what I try to tell them. But you will be wounded because you will deal with the obese patient. We had a patient today was 650 pounds with issues. It's not the same as the 160-pound patient we had the week before. So you're going to meet all different kinds of patients, and you got to work them up. And when you have a complication or the ultimate complication of death, the question then is immediately it is two things happen that I have found over the years. There's a self-blame and a blame you game that you feel is happening, because all of a sudden, I mean, I thought I saw the cult, I thought I saw the, I thought I reviewed the MRI, I thought I did this, everything was all set to go. And then the question is, oh my God, man, Raju had a death. What the shit happened, man? Did he do so? And then you go to the lounge and you feel very lonely. So there's a two-pronged attack, one on myself, and I wonder how much is coming from outside. So these are the things that I have been through, but it just makes yourself stronger to do the best that you can and better that you were, not to drink and get back on the horse. Thank you for listening.
Yeah, thanks for those comments and that perspective. Absolutely.
Just one more thing to add. Just, I know we have some younger residents in here, and just one of the things that I found, we, even if it's not just like a complication or a death or something like that, we deliver bad news all the time, cancer diagnoses, all these different things. One of the strategies that I learned early on in med school that's been really beneficial and patients have been very receptive to it is you come out with it first. You come out with the, what happened. You tell them exactly what happened, and then you sit and you let them be the person that responds to however long it takes them, however long it's a very hard thing to do. We want to jump in, we want to explain things, we want to tell everyone, what happened and why it happened. And a lot of the time they just need time to kind of absorb what's going on. And so I found that even if it takes, 5, 10, 15 minutes, you tell them what happened, you sit there, you let them take the time that they need. And everyone's going to be different. Some people are going to want to know immediately and ask a bunch of questions. Other people are going to need to sit with it for a little bit. And I think you allowing to just exist in the space with them is a very important thing to do.
Couldn't agree more. I mean, I think, that's the first should be foregone conclusion of leaning into a complication. And of course, I shared a pretty dramatic, acute on-table death, which, is pretty jarring. But the patient that's in the hospital for weeks and months, and you go see them every day, and that's its own it's got its own type of impact. Um, if you're a pediatric surgeon and you have a circumcision that dehisces, that's not life-threatening, but that's a big deal to you and to the patient's family and to the patient. I mean, a vesicovaginal fistula repair that breaks down. So I don't think that the gravity or acuity of the complication is as big of a deal as the impact that it has. And we're all a little bit different. We're introverts, we're extroverts, we have coping strategies, we're in relationships with support systems, or not. But I think fundamentally, going back to what you said, is just being there. It may not be particularly comfortable to exist in some silence. I think, allowing yourself to be a little bit vulnerable is perfectly fine. And, basic things like sitting down when sharing bad news. I think you're totally spot on.
Aditya, one last comment I'll just make myself, which is something I've always struggled with, is the concept that, look, I can stand here and say I've done 1,800 perks and I've had one death, which actually is lower than expected technically. But for that patient, it happened 100% of the time. Doesn't matter what my numbers are, right? Doesn't matter if I have a 2% sepsis rate. The people that got sepsis got it 100% of the time, right? And I think that is the struggle, is that we do, especially when it comes to these severe complications, we hold ourselves to a standard that sometimes is hard to meet. It's my partner Doug Dahl in Boston used to say, look, man, if you bat 333 in Major League Baseball, you go to the Hall of Fame. He said, if a third of my patients after prostatectomy didn't have a leak and 2/3 did, I'd be out of a job, right? You know what I mean? And we hold ourselves to this standard. And, again, it is, when you take a step back and think, well, to that patient, even though I said, this complication is incredibly rare, and it almost never happens. To that patient, it happened 100% of the time, or to that family. And I think that's another just very powerful thing to remember for me, right, is that we can talk about our experience and our success rates and what we'd expect, but we have to take also ourselves out of that and remember that each patient's experience is their singular experience, if that makes sense. And I think that also colors a lot of the way that I view my discussion with these families.
Couldn't agree more. Yeah, and I mean, it can impact how we consent patients or any number of things. And, for more routine stuff, um, without getting too far off the track here, I always try to talk about the common stuff and the bad stuff, and what those denominators are that are a part of the conversation. I think is a little bit of a moving part, and even in that, there's some probably room for individualization. But definitely appreciate that comment, and I think it's also worth just like remembering that there's been various terms here, and while this is awful for us, we are a distant second or third from the patient and people that are kind of front and center. Okay, so I just you've heard a couple of times that you're not alone, and we're kind of talking about this phenomenon. So over the next 10-15 minutes, I'll share a little bit about what all is out there in terms of incidence, prevalence, and then on a hopefully at a positive note, what are some things that we can do at an individual level, at a departmental level, and institutional level to help support each other and take care of ourselves. So we're talking about a phenomenon. It's been coined a couple of different terms, including second victim. And this is essentially a clinician involved in unanticipated adverse patient event, medical error, or patient-related injury who becomes victimized in the sense that they're also traumatized by the event. And here's a couple of quotes. No other profession that demands elite performance has devoted so little to the well-being of its practitioners. And we all hide our grief, suffer in silence. The pain can be close to debilitating. These are a couple of excerpts from manuscripts on this topic. And here's one directly from a urologist. I felt and feel very guilty, but I remain disappointed by the lack of support from my employer. I felt I was treated like a criminal first rather than any duty of care to me as an employee doing his job. I found it very difficult to talk about at home. It was only the support of my colleagues that enabled me to get through that period. And this is, it's a recurring theme. So we'll talk a little bit about the prevalence literature, the incidence literature, and this bi-directional relationship between errors, complications, and burnout. So we know that this is not surgeon specific. Everybody across the spectrum, from trainees to senior physicians, are impacted. There does appear to be a bimodal distribution of impact. If you think about it, to me, it kind of makes sense early in your career. If you have a bad outcome, you may lose the confidence to do that operation. You may lose the confidence to do any operations or change your practice dramatically. And then it's also well reported and described that as surgeons enter the twilight of their career, and they may have some questions about their ability to have kept up with the technology, to kept up with the various pathways and so forth. They may be second guessing their ability to perform. And why is this so impactful for us? Because the activity of the surgeon is so directly linked to the outcome. We feel so singularly responsible, like was mentioned, you know, something I did led to your death or this outcome, whether or not it was an error. That's where something was overlooked or a misstep. If you put somebody on DVT prophylaxis and they had a DVT, that's a complication. If you forgot to put them on DVT prophylaxis and they had DVT, that's an error. And there's actually some data that suggests that errors versus complications have differential impact on the provider. This is not provider specific, as I'd mentioned. It really does happen to everybody. And if we start looking at the literature that's out there, so one of the first kind of major landmark studies was from 2007. Waterman and colleagues, almost 3,000 doctors. A third of these were surgeons in North America, and errors were complicated into near misses, minor errors, or serious errors. And these authors report that following these errors, 61% felt anxious about further errors. 44 reported loss of confidence. 40% of the patients slept less well. 13% were concerned with reputation. And almost uniformly, everybody felt unsupported after errors, and the likelihood of being sued correlated with increased stress after an error. If we dig in a little bit just within surgeons, this was a kind of a follow-up study. And in this group of surgeons only, the majority were male. Most of them were general surgeons. And almost 1 out of 8 reported an impaired ability to do their job, impact on concentration, sleep, leisure activity. Almost 1 in 5 people didn't speak to anybody. Alcohol consumption was increased. And peer professional support was very, very sparsely utilized at 1.6%. And of those that reached out for peer support, most felt that the experience was not overly useful or productive. Kathleen Kobayashi and her group recently published some data in an AUA survey. And during the course of your practice or training, have you ever experienced a serious complication? This is 95% of people that did. And again, we see that among our own community, among urologists, anxiety, guilt, grief, reputational worry, anger were extremely prevalent. They could last for a while. And unfortunately, I think everybody's probably heard of, some really awful cases within our community where shortly after a complication, there were even reports of suicide. There were a couple of cases within just a few years in the pediatric urology community. The psychosocial impact in a recent review, that we see these largely negative emotional behavioral responses, largely unreported. Again, there might be this biphasic relationship at the early end of this career, and then at the later end of the career, a general reluctance to seek help, and how this was kind of impacted based on the relationship is not based on the complication is not well described. So these same authors made some conclusions that complications should be defined in terms of surgeon health, prevention, education, and awareness are needed. Proactive support at the time of this in 2021 has not been studied, subsequently has. And tailored psychosocial support should be offered after complications, and the efficacy and impact of support should be evaluated. So, one such study from Bournemouth University, this is in the UK, they've done a lot of work on errors, complication, and impact on surgeons. A large survey-based study, recall an event randomized to an error complication, along with contributing factors. And they found in this prospective study that these feelings of anxiety, irritability, sleep disturbance, substance abuse were quite prevalent. Almost a post-traumatic syndrome type of symptomology in about a third of patients. And everybody agreed that training should prepare a surgeon for an adverse event, but almost no one thought that it did. And in this study, they were kind of the initial team to report some of the differential impact of errors and complications. If you had an error, you're significantly more likely to experience sleep problems, anxiety, alcohol consumption. Trainees face all the same issues, and they were well represented in the study. And then there were some typical studies. So, we've study after study is starting to demonstrate that this is a real problem with real impact on many, many domains of wellness. And what can we do about it? So there is guidance. This is a handbook for best practices from the Royal College of Surgeons. And one of the things that they talk about are resilience. And resilience is a process of adapting well in the face of adversity, trauma, any source of stress, or the ability to bounce back, or a complex combination of characteristics that protect against long-term negative impact of stressors. And what it isn't, it's hard. It's not mental toughness or hardiness. It's not either a fixed trait that you have or don't have, or being immune to the effects of adverse experience. That's not what we're talking about. And this is kind of a double-edged sword. It suggests that there's some feature or characteristic inherent to us that allows us to cope better, for worse. And resilience training is something that's been described. Cons are suggest individual control. It does absolve some institutions with responsibility, and it might be another stick to beat us with. You shouldn't be struggling. You should be resilient. However, on a positive note, it can facilitate individual coping after adverse effects, and it's beneficial potentially to the provider as a whole. And why is there some effort to focus on individualized provider? Well, organizational, systemic, cultural change can be slow, and in the interim, surgeons continue to suffer. No matter how good things go and how much things change, things are always going to go wrong, and how we synthesize that will be a dynamic process. And then also because doctors and surgeons are no more resilient than the general population. And if you look at a couple of surveys that are out there looking at various resilience scores, surgeons tend to do about as well or slightly worse than the general population when it comes to resilience. There have been some efforts to prepare surgeons, including resilience training, and one form of that is acceptance and commitment therapy, where there's a focus on acceptance, values, contextual, allowing one to kind of interact and interface with the event as opposed to thinking or acting like it didn't happen. And in the UK, there was a randomized study of 68 trainees, and after acceptance and commitment therapy, the authors reported increases in resilience, decreases in personal burnout, decreases in psychological distress, increases in self-compassion, and this was the kind of the first prospective data that suggests that we can intervene and potentially impact things. So, supporting surgeons after adverse effects, it's complicated. There's a lack of knowledge about processes after an adverse event. There's no clear timeline of when somebody should be approached. Should it be opt in or opt out? little guidance for those who provide support, peer support, we'll talk about in a moment. And there's no clarity around whether the surgeon should continue to work, and if not, how their return to work should be supported. Now, all of us can imagine a scenario where we have a unexpected, particularly adverse event. Is it safe and is it appropriate to continue on that day or the next day? Especially given the fact that there's not a lot of redundancy built into our roles. With all that being acknowledged, what can we do about this? Awareness, thank you for Lawrence and for the whole department having me out here to talk about this, just normalizing it, have it be a part of the conversation. Structured emotional support to peers and colleagues, structured debriefings. We have a system here where after any claving 3 complication, we've got kind of a buddy system where we reach out and talk about things, counseling, support groups. I've actually found, as I've gained some interest and exposure due to this field, that residents are actually amazing in terms of supporting and talking through these types of things with each other. A positive morbidity and mortality conference where you focus on the process, and then also in terms of process improvement, and then really try to build each other up, periodically having maybe a reverse M&M where there was some outstanding care, or interfacing with these types of conversations somewhat regularly, and then resilience through training, coaching, and mentoring for anybody that is in the department, or certainly anybody that kind of reaches out. A slide specific to training. This is a timeline that's been described where early intervention may be key. So if an event takes place, there's chaos and an accident response, and how and why did this happen? Then there's, I would say, intrusive reflections. What did I miss? Restoring integrity. What will other think? It all resonates like so profoundly. How much trouble am I in? Where can I turn to from help? And then importantly, moving on can take a lot of different shapes, from dropping out to surviving to thriving. And of course, we want people on the thriving end of the spectrum. So can't emphasize enough to the trainees, if you're feeling these types of impact, reach out to your colleagues, and I'm sure that the program directors and community over there would help you find some support. The building community part of it is massive. Instituting debriefings after complications, coaching to help reduce emotional toll, including mindfulness, journaling, developing networks, peer support locally and virtually. I mean, these are things that we can, really do. It is somewhat informal starting tomorrow. And then thinking about setting up your own peer support network. If this resonates with anybody, peer support is really a way that we can make a change. So there's some general principles focused on empathy, genuineness, positivity, lack of judgment. The American Medical Association has a step-by-step guide for setting up peer support programs, making the case to leadership that this is essential, both from a wellness perspective, longevity of practice perspective. It's kind of a no-brainer. If a surgeon decides to leave, that's a big hit to any health system. Deciding which healthcare members might be interested in serving, and then forming a peer support with strong communication skills. There are training programs that are put together, again, through the AMA and others as well, and then activate this and provide resources. We have a peer support program at UC San Diego where you can anonymously reach out and get paired up. There's a liaison that supports the program, and I feel very fortunate to be involved with that. It's a great team of everybody, across disciplines. So as we kind of get close to concluding, complications have a profound impact on all of us. Traditionally, we've coped with complications and their impact in silence, in a culture of perfectionism and silent suffering. Many of us are unprepared to handle the emotional toll of adverse events. It's also an extremely individual process. And there's a growing movement to openly address and educate in on how to best deal with this at an individual level, at a departmental level, and an institutional level. So I hope this continues or sparks a conversation at Tulane. I have my contact information here. Sometimes talking to somebody who's half a step removed can be useful. And with that, again, I thank you for your time, your attention, your comments, and for the invitation. Happy to
Aditya,
hear any thoughts.
yeah.
Please.
So, when I was thinking about this problem, years ago, I still don't think that the institutions are doing enough for, I don't want to use the word wounded surgeon, but wounded physician, because, I could be doing a colonoscopy and I can perforate and major sepsis can happen. So the Kaiser Permanente, the LCMC where we are part of, each of these institutions need to have a support system for physician. So my thought was that there needs to be either at every hospital or a system a group which is voluntary, includes somebody from surgeon like a senior surgeon, a senior physician, a clergy. And now clergies are of different religions depending on the faith of the physician, and a hospital layperson could be a senior nurse or whoever to form the core where they have a place that they can have whether it's an administration area somewhere called the physician's resource center or physician's massage center. What I have to say is just name is something that is ubiquitous, but where I can go sit down and talk to somebody, or be quiet and then they can talk to me. Um, this is something that hospital, eat hospital. Let's get bigger and make more money. But the people who drive the system need to be taken care of.
Absolutely. I couldn't agree more. And for it to function, there does need to be some infrastructure, and with some infrastructure, generally requires some administrative support. At the very least, I think you need to have kind of a physician champion and an administrator who can help develop, first of all, recruit people that are interested, develop some training, develop some community, go out to various departments and share this resource. And all that takes some time and organization. And, as you allude to, everybody's busy. Nobody's got a half a day a week to kind of spend on this, but it does take some acknowledgement that this is real and some support. And for that to happen, a champion, I would say, or a group of doctors that say, "Hey, this is actually something important to us." Because I think that would be the ideal state, and there's still plenty of questions on how best to implement this. Again, does everybody get prospectively tapped if there's a complication of certain magnitude, or is it just like a reach out if you've had a complication? I think those are still unanswered questions. But in an ideal state, I think you'd at least get a ping that, hey, we're here for you if you need and want to talk.
My name is Jacob. I'm one of the third-year residents here. Might be a personal question, sorry. But when your mind wanders and one of these patients that you've had a complication comes up, what do you remember about them? I guess the problem that I'm having is that when it happens for me, it's hard to get past the complication that happened, if it was a death or not, and try to remember the other things about them too.
Yeah, no, I think it's a great question. And so, I mean, fortunately, my kind of list of particularly noteworthy complications is finite enough where I can remember them. And this is just me personally. When I when I say my prayers, I literally pray for each and every one of them. And a part of that is visualizing them and their family and remembering them. And beyond it, because most of the time there's something beyond just the complication, that leads to more communication, more relationship development. And on the one hand, it's just kind of there's something to be said about remembering them and honoring them. And these are not all, big M's. Interestingly, though, when I was asked a similar question, somebody else made a comment that at some point we have to kind of forgive ourselves a little bit. And I'm not sure if, every other day, daily remembrance of everyone is helpful or not helpful. But I think maybe what you're alluding to and what I try to do is remember them as a person and not as a complication.
Gotcha. Thanks. I guess follow up. Sorry.
Can I say one more thing before we quit, Aditya?
Please, please.
So the first thing we all have to do is to make sure that we are well prepared for what we are about to do. The pre-op, the immediate pre-op, all the workup and all that is done. That can help heal things better. But finally, I will never forget what I heard in a story. This is the wife of a patient whose husband died. And she said, the surgeon goes home to sleep with his wife. I don't have a husband anymore. Thank you. Aditya.
Yeah, I mean that's profound, and while this is massively important to us, it is important to remember that for the patient and their family, they're front and center. Well, again, I really you all were so engaged, and I learned as much from you all as I'm sure I imparted for you all. Thanks for being so interactive. I appreciate that. Happy to, this is just a beginning or one of the kind of stops along this journey for you all. And I have no doubt that there's somebody in there that's going to help kind of elevate this topic to a level that can be beneficial to your whole department and institution. So thanks. Look forward to hopefully seeing some of you at the AUA, and I appreciate the invitation.
Thank you.
Hey, thanks again. Great job.